Welcome to Coffee with Kyle number 15. I'm Kyle Ridgway. Good evening. For the second night in a row, we've actually got Coffee with Kyle with a twist. We have Beer with Ridge. And tonight I think I'll say a little bit about what I'm drinking before we get into what I want to talk about. So I'm drinking Madam Psychosis, a New England style IPA from Fiction Brewing here in Denver, Colorado. So for those of you out there that want to follow along on that, so cheers. Happy Friday night. In any case, today what I wanted to talk about generally was the concept of prior plausibility or scientific plausibility or physiologic plausibility or mechanistic plausibility and the evidence hierarchy and how it relates to evidence-based practice, evidence-based medicine, however you want to term it. So those of you who are watching who are clinicians of any field will be very familiar with the concept of evidence-based practice or evidence-based medicine. As one of my friends and colleagues has written about very eloquently and in a lot of detail, Kenny Veneer talks about a lot how evidence-based practice is actually misinterpreted sometimes and actually misapplied. So I'll link to some of his fantastic blog posts over at Physiological rather. So to start with, the evidence-based hierarchy is biased towards RCTs and clinical outcome studies. And that's okay. That's actually a good thing. And I don't want any of this conversation or what I'm about to say to suggest otherwise. We need the evidence hierarchy. We need RCTs. We need more of them. We need better evidence, and we need to utilize that evidence. But that being said, I've always thought, or maybe I've come to the conclusion, that the evidence hierarchy assumes that the user of the hierarchy is well versed in all of the basic science and prior plausibility that underlays the hierarchy. And so the way that I look at it, right, the way it depends on how you draw it, at the very upper echelon, we basically have meta-analyses of meta-analyses, which, don't get me started, that doesn't even make sense. Meta-analyses, systematic reviews, well-designed, multi-center, double-blind, randomized control trials, all the way down to expert opinion, animal studies, or just whatever I say. But like I said, I think this hierarchy, this triangle, assumes that the user is well-versed in everything that surrounds that triangle. And what I mean by that is that underneath, or the foundation of the evidence-based hierarchy, the evidence-based triangle, the evidence-based pyramid, evidence-based practice, whatever buzzword you want to use, please, by all means, use it. Underneath that lays basic physiology, basic physics, psychology, chemistry, biology, all of these other fields of basic science underlay or form the foundation to the evidence-based hierarchy. And therefore, I would postulate, or I would argue, or I would encourage us to consider that in order to properly use or interact with the evidence-based hierarchy, we need to be well-versed in basic science. And I mean really basic science. Physics, chemistry, biology, physiology, maybe even psychology you could throw in there. And the reason is this. We could probably design a study, an outcomes-based study, a clinically based study that may show that craniosacral therapy is effective in reducing pain in certain clinical conditions. That may be true when comparing it to nothing. It might actually be true in comparing it to a placebo. It may even be true in comparing it to some other singular sham intervention. It may even be true in comparing it to another intervention that we currently utilize. We could do the same thing for Reiki. We could do the same thing for my good friend Kenny Veneer's favorite intervention, cabbage rubbing, where you just rub cabbage on the skin of the affected area and the person feels a little bit better. It's an intervention, apparently. You can ask Kenny all about it. We could compare that to the kitchen sink approach, or we could study the kitchen sink approach. The reason that I bring all this up is, what if those RCTs were positive? And I ask students this a lot. If there was an RCT that said your patient with cervicogenic headache would benefit from Reiki, assessing their energy fields, not placing the hands on the person, would you do it? Would you take a Reiki certification? And would you use Reiki with your patients? And I have yet to find a DPT student, thank goodness, that says yes. And why is the reason? I always ask them that, why? And they say, well, it doesn't make any sense. The theoretical construct doesn't make sense. The assumptions that we're making about why it works doesn't make sense. The intervention doesn't make sense. So if it works, it doesn't work for the reasons that they postulated. And then, because DPT students are very smart, or, for the most part have some very decent exposure to research methods and evidence-based practice. And they say, maybe it was the time with a caring practitioner. Maybe it was some non-specific effects or some meaning effects, or maybe there's something within the construct and everything that goes on with Reiki that's actually fairly, maybe not highly effective, but is maybe something that's worthwhile. We just need to tease out what that thing is. So it gets deeper and more complicated, and I think more layered and multi-dimensional than that, because as physical therapists, and my sense is, and I've said this to Sandy Hilton a lot, that I think physical therapists are much more like surgeons than we'd care to admit, and that's not an insult to surgeons nor a compliment to physical therapists. What I mean by that is that we like to do things to people, and I think we need to come to terms with that. I'm guilty of that. I know all of us are as physical therapists. And because of that, we focus a lot on interventions. What works? That's the thing that we really get caught up upon. But we always need to ask a more foundational question with whatever RCT that we're interacting with, whether it's our pet intervention or someone else's intervention that we want to argue against because it's our real hobby horse, axe to grind intervention that we don't like. We need to ask, why does that intervention work? Now that's a different line of inquiry. It's still important. It's still clinical and bedside and maybe even benchside research into mechanisms. We need to look at the plausibility of why it may work based on what we know from all these basic science and other research disciplines, and then how it works through mechanistic research of understanding the mechanisms of actions of that treatment. Because any time that we are looking at an RCT study of a clinical intervention, especially in rehabilitation where the effects are so multifactorial and the interventions are not physiologically specific or even psychologically specific, we have to ask ourselves, what are our assumptions of the why that intervention works? What's the theoretical construct or the theory presented? In other words, what stories are we telling leading up to that RCT, right? Because no one just says, we're studying this intervention just because. There's a plausible reason. There's either some case series data or some plausible reason why, and that plausible reason often has a theoretical construct. Just because it has a theoretical construct or proposed theoretical mechanism doesn't mean that that theoretical mechanism aligns with deeper scientific and physiologic principles. So what can happen, or an error in thinking that I feel like I've made a lot as a student and a young clinician, and that I kind of observe a lot personally, whether or not it's true globally, is that we see a study, regardless of how well designed, different story for a different day, that shows some positive effect of a certain intervention. And instead of taking that at the very face value of what we can take it, which is essentially in that environment with those patients, this specific intervention had this effect. We fill in this black box gap and we use that as validation that the story we told, or the reason that we theorize that it works, the mechanism, has thus been validated. And that's not actually true. We need different mechanistic research to validate that, and that's way outside of my explanation expertise as well as my clinical and definitely my research expertise. But it's important to consider, so I'm going to repeat it again. If we study an intervention in an intervention trial, whether that's an effectiveness trial or an efficacy trial or any randomized control trial where we're studying an intervention, that does not validate the theoretical construct or proposed mechanisms of that intervention. Because the intervention may actually work, but the RCT doesn't tell us why. And I think as a profession, in physical therapy especially, but any therapeutic rehabilitation counseling discipline, we always need to be asking ourselves that question, why, even if we can't answer it. So again, even if it works, it doesn't validate the theory or construct. And there's a physical therapist who I think is quite fascinating, who's studied some philosophy and written quite extensively on the concept of causal reasoning. And his name is Sean Collins. He's a cardiovascular and pulmonary board-certified clinical specialist. And I will link to some of his writing in the comments, because he basically argues that the way to implement evidence-based practice is we need to teach our students how to causally reason and make causal networks and insert the clinical evidence and the physiologic knowledge into that network to make better decisions and to reason better. And I found that fascinating. And again, that's way outside my realm of expertise. A lot of dense philosophical terms in there, but totally worth it to engage with. And I've spoken previously about this in not a lot of detail, but we have to remember that most of the time, really well-controlled specific research studies answer a single question. That's not bad. That's actually really important. And the more narrow that we can get that question, the more control we can have, the more confidence we can have in the result. And actually, the more it can tell us about less. And therefore, we can use all of these little pieces that tell us more to build a picture. Because I think what we need to realize is we need to draw the forest from the many, many trees. And the many, many trees are different ways of researching and understanding things, and different disciplines and different scientific foundations. Because it goes one level deeper, maybe one dimension, it adds another dimension, is we haven't even talked about what are we treating, because now we open up the whole box in the same types of reasoning and research lines of research when we talk about what are we treating. We need to understand very deeply what we're treating. And that's both at a clinical level, if it's a symptom or a certain patient presentation or a syndrome, whether that's pain, shortness of breath, fatigue, fibromyalgia, chronic fatigue syndrome, anything of that nature that's clinically oriented, as well as we need to really understand the physiology of the pathologies we may be dealing with, whether that's tissue damage, whether that's medical conditions, whether that's other physiologic derangements, because that's part of the plausibility picture. But it's also, in order to construct reasonable hypotheses about what works, we can't just know about physiology and basic science generally. We have to know about the physiology and basic science and mechanisms and everything about what it is we're actually treating. Because then we'll be able to find when there's not a plausible link there, or when we find something that works that we can't find a plausible link, we can come in and try to find the mechanism. And I think that's really important. And again, and I talked about this previously, I can't remember on which Coffee with Kyle, but I'll link to it, is then we also need to look at what predicts outcomes regardless of intervention. And that opens the door to whether the prediction of outcome variables or factors are modifiable versus non-modifiable. This is very well characterized in the heart disease and the coronary artery disease literature, as far as modifiable versus non-modifiable risk factors for heart disease and non-modifiable versus modifiable risk factors for bad outcomes, hospitalizations, death, all of those things. Because once we figure out what predicts outcomes and what we think is modifiable that predicts outcomes, now we can actually study, A, whether we can modify that variable or construct, and B, whether modifying it actually leads to better outcomes or not. And so I hope that kind of illustrates the complexity of evidence-based practice. And what I think sometimes happens is we get into some shouting matches or some arguments about, well, this thing works for that, or this thing works for that. And first of all, we haven't even defined the that, or we've defined it very poorly. But second of all, it's almost like an RCT ping pong match. Each side's kind of throwing, well, here's a nice case cohort study, here's an RCT, the data suggests this. And we never open the box to a deeper and more dimensional approach to the reasoning and discussion around what we should do. And I feel like that we need to induce a little more nuance and a little more specificity as well as breadth to these discussions about what the evidence says to treat certain conditions. Because like I talked about previously, when you try to apply population means research to an individual, it's really complicated and it's actually probably really complex. And therefore, we need a lot of different viewpoints and expertise to kind of triangulate these problems and the potential answers. So that's what I'll leave you with here on a Friday evening. Cheers. I hope you were also out there enjoying your favorite beer, hopefully an IPA. And it was good to see you. Have a great day. Have a great weekend.